Okay, hello everyone. Good morning. We're gonna be doing ENT, and I made the slide so you can see my priority for you learning ENT is only good music. And Dr. Madhura has kindly agreed to do the teaching. And I'm very, very grateful for that. So I'm gonna let her take over and we'll start.
Okay, so hello everyone, both everyone in the call and also whoever's seen the recording. So my name is Madhura. I'm one of the junior doctors at UHSussex, and today's presentation is about high yield ENT topics for your upcoming exams. Each slide is basically like a snapshot of the core information that you will need to know. And obviously the presentation was kindly made by Rupali. So let's get started. So you can see on this slide, these are the core topics that we will be covering. It's obviously a range, and like I said, each slide will have the core information. So starting off with a general like diagram of what the ear components are. You have the outer ear, which is anything in front of the tympanic membrane. So it includes the pinna, which is like the outer part of the ear, and also the external auditory canal. Then you have the inner ear, which is that small box-like shape behind the tympanic membrane, and that contains three of the small bones, which is malleus, incus, and stapes. And then finally behind that, you have the inner ear. And essentially the way sound works is, it goes in via the outer ear, then it hits our stapes bone, which then sends vibrations into the cochlea via the labyrinth. And this is really important for your hearing and balance. So hopefully that's just a bit of a clue about how, when each part is affected, how it then presents in us. So starting off with otitis externa. So this is an infection of the outer ear, commonly caused by Staph aureus, and you can also get some types of dermatitis, such as seborrheic dermatitis or contact dermatitis, causing this sort of inflammation. If someone has, diabetes or is immunosuppressed, then Pseudomonas bacteria is more likely to be the causative organism. Other causes of otitis externa can be trauma, such as using earbuds. Sometimes the little kids, they might be trying to put other things like matchsticks inside their ears. So anything that can push wax in or interfere with normal epithelial migration of dead skin outside the ear can cause that inflammation. You may also hear it referred to as swimmer's ear. Fine. So how these sort of patients tend to present is with ear pain. They might complain of itching or discharge from the ear. And when you do an examination, if you palpate their tragus, might be painful. And on otoscopy, that might also be painful. Sometimes on otoscopy, the ear canal can be so swollen that you can't actually see the tympanic membrane. And they may also get some lymphadenopathy. In terms of management, it depends on, their symptoms. If you can see a good degree of discharge and inflammation inside the ear, they may benefit from some topical antibiotics. So not systemic. So a common one would be like an ear spray that has antibiotics, so it can nicely hit that area, and also some steroids to help reduce that inflammation. You'd also give some more holistic management, such as pain relief, tell them to avoid having water inside the ear, so that means avoiding swimming. Sometimes you give advice to put some like cotton buds with Vaseline in your ear when you're showering to avoid water getting in. And oral toilet essentially is about clearing out any impacted wax, usually through like irrigation or microsuction. Fine. So moving on to malignant otitis externa, which is where you can have a spread of infection from an otitis externa to the temporal bone, and it's usually caused by Pseudomonas. In terms of presentation, so it presents very similarly to otitis externa, but you can also get some facial nerve palsy that starts with that otalgia, and sometimes people can get ipsilateral jaw pain. With regards to management, because there's a spread to bone, we're more worried, especially because of sepsis. So we want an urgent ENT review so that they can investigate further, clear out the infection, and do some stronger antibiotics, and not the topical antibiotics we were talking about earlier. Fine. Please feel free to stop me at any point if there are any questions. So, moving inside the ear now, we're now in the media. So if you remember that picture, the media is the area just behind the tympanic membrane, and you can get infection of that area as well. It's very common in children, and a common story is, my child had a cough, cold, story reminiscent of like an upper respiratory tract infection, and now they're tugging at the ear, they've got this ear pain, they're feeling really unwell. And other causes of otitis media is also bacterial infections such as Streptococcus or Haemophilus.
Just to add on, sorry, Madhura, in your pediatric ED, so because this was the first time I was doing peds ED, whenever there's a sick child and you're trying to send somebody home, you have to do an ear, nose, and throat examination, because you have to make sure that that's not one of the sources of infection, because kids get ear infections all the time. It's very common. So no matter what they've presented with, we always check the ear, nose, and throat for kids. Go ahead.
Yeah, no, that's definitely a good point with kids, but just as it's so common. Another thing that parents might know is their hearing is not as good because of the fluid buildup causing conductive hearing loss. They may also say a story that, okay, the pain was getting really, really bad, and then all of a sudden they had this sudden relief of the pain, and then they're getting some fluid draining from the ear. They might notice on their pillow, and that would be a sign of the eardrum perforating. And when the eardrum perforates, that fluids or pus cells building up behind the eardrum is now free to flow. On otoscopy, you might see a bulging tympanic membrane. Essentially, it's bulging because of that fluid buildup and that inflammation. And when it bulges, it loses that nice conical light reflex, which again shows that there is some sort of effusion behind the tympanic membrane. If there's inflammation, the tympanic membrane will also appear more opaque or red. With regards to management, you would, if they're not systemically unwell, you would usually advise, okay, it can be self-limiting within 3 days, but if it's lasting more than 3 days, or the patient is unwell or has red flag features, such as being younger than 2 years old, but having bilateral otitis media, having that perforation, or if they're immunocompromised, then you would want antibiotics. So you can see the antibiotics on the screen there. If a tympanic membrane is perforated, it can take up to 6 weeks to heal, and usually there's no other intervention needed. But if it's lasting more than 6 weeks, then that would require an ENT referral. Fine, so that's acute otitis media. So moving on now to glue ear, which is similar to otitis media, but instead of the symptoms being caused by an infection and therefore pus, it's just a collection of fluids within the middle ear space. And it's also a very common cause of hearing impairment in children. Because of the hearing impairment, it can present as speech delay or the child being more clumsy. Usual management starts off with a bit of a watch and wait, usually for 3 months. If there's no resolution, you would then consider something called a grommet insertion. So a grommet is a tiny tube and essentially helps equalize the pressure between the middle and outer ear, and that will fall out by itself with normal like epithelial migration. If a patient is getting recurrent glue ear, you may also consider an adenoidectomy. An adenoid is basically a gland at the back of your throat near the nasal passage. And when someone's getting recurrent infections, they swell and they really prevent the drainage from the middle ear, causing their symptoms of that hearing loss and the pain. Everyone okay for me to move on?
Yep.
Okay, so moving on to I always struggle to pronounce this, cholesteatoma. So essentially, this is a non-cancerous growth of the squamous epithelium, and it's trapped within the skull base, and it causes some local destruction at the top of the ear. And the way it presents is with a malodorous white ear discharge. They may complain of some conductive hearing loss, feeling more unbalanced, and with tinnitus. But usually there's no pain with this sort of presentation. On otoscopy, you would usually see a attic crust, which is in the uppermost part of the eardrum. It's very easy to miss because it's not painful. And when you would do an otoscopy, you would have to really make sure to swing your otoscope right round to the tops just to make sure that there's nothing kind of growing there. If you do see something or you have a suspicion of it, you would refer to ENT on an urgent basis so that they can do a CT head, because basically you want to rule out any erosion of the petrous bones, and consider surgical removal. Right. Okay. Another ear condition that we worry about is acoustic neuroma or vestibular schwannoma. These are associated generally with neurofibromatosis type 2, which is a genetic disorder where tumors grow on nerves. So with the vestibular schwannoma, they develop on the auditory nerve. The way it presents can be with vertigo, hearing loss, tinnitus, and when you do an examination, you may notice signs associated with the vestibular, facial, or trigeminal nerve. One important sign I would say here to remember is if they have an absent corneal reflex, so that's related to cranial nerve 1 and 7, then that would really increase your clinical suspicion of an acoustic neuroma. In terms of management, you would refer via the 2-week wait pathway to the ENT team.
Mm-hmm.
Okay, moving on now. So before we were talking very much about different parts of the ear, now moving on more to hearing loss. So there's 2 types of hearing loss. You have conductive and sensory neural. With conductive hearing loss, it's where your ability to hear through air, so from the outside into your ear, is reduced. So normally we hear better from the air than through our bone, but if that is reduced, then that would be considered conductive hearing loss. It's usually caused by things that would then prevent vibrations going from the outer ear into the inner ear, and that's things like wax, infection, glue ear, foreign bodies, and so on. In contrast, sensory neural hearing loss is more to do with processing of those vibrations. Again, can be caused by infection, but also can be caused by acoustic neuromas, noise damage, ototoxic drugs, which we'll cover later, and presbyocusis. In order to distinguish between conductive hearing loss and sensory neural hearing loss, you would use a test called Rennie's and Weber's. So you guys might have already had opportunities to practice this during your studies. Essentially, you would use a tuning fork, and like I was saying earlier, your hearing through air should be better than bone. So you would you would get the tuning fork vibrating and then place it on the bone behind the ear. And then when the patient stops hearing the vibration on their bone, you would then move it in front of their ear. If they can still hear it in front of their ear, that's a good thing because it shows that their sensitivity to air conduction is better to bone conduction. However, if that's impaired, that is indicative of some sort of hearing loss, whether sensorineural or conductive. To then distinguish between those two, you would then do the Weber's test. So again, you'll hit your tuning fork against something to get it to vibrate, and then you put it in the middle of their forehead, and then you ask them which side can you hear the vibration. If it localizes to the same ear that you were having a negative Rennie's test, then that would be a conductive hearing loss. But if it localizes to the other side, then the original ear, you would then think it has sensory neural hearing loss. It's one of those things, it's a little bit tricky to get your head around. The best way I would say to kind of process it is to practice and see it for yourself.
I definitely agree. Do as many questions as you can on Rennie's and Weber's till date. I still get it wrong because you forget after a while, and then you have
Definitely.
to keep practicing.
Yeah.
So do as many questions on these tests as you can because it's very high yield.
Yeah. Yeah, definitely. Okay. Now moving on to BPPV. So this is quite a common presentation, especially in general practice, and essentially is an inner ear disorder caused by calcium carbonate crystals in the semicircular canals in the inner ear. And when they are kind of shifted, so a typical story is, oh, I was turning over in bed, I was looking to the side, and suddenly I had this sensation of vertigo. Usually lasts a couple of seconds, and diagnosis is with the Dix-Hallpike maneuver, where you're intentionally shifting those crystals to see if you can reproduce that vertigo. And then the management is with the Epley maneuver, where you reset the crystals. I would say the most important thing with BPV is just knowing, yeah, usually lasts seconds, the vertigo. And as you can see in the name, it's positional, tends to come on when someone's moving position. With vestibular neuronitis, you have inflammation of the vestibular nerve, and again, you have these symptoms of vertigo. But the difference between this and BPPV, here the vertigo can last hours or days. So when you're taking a history, seeing a question stem, looking at the duration really helps. And it's usually preceded by a viral infection. With regards to management, tends to be prochlorperazine just to help with the symptoms of vertigo. You also have viral labyrinthitis. So all of these things all do sound quite similar. There's usually kind of one point in a question stem that helps distinguish. So viral labyrinthitis is quite similar to neuronitis. I would say the main difference is that viral labyrinthitis tends to have hearing loss or tinnitus associated with it. So it seems quite similar. You have these vertigo attacks also lasting hours and days, but with the addition of hearing loss or tinnitus. In terms of when you do an examination, you can get horizontal nystagmus, as well as gait disturbance because of the vestibular nerve. In terms of management, if it's come on quite suddenly, that would raise your alarm bells and you'd want to refer to ENT. But if it's come on a bit more gradually, it may be self-limiting and can be managed in primary care. And finally, we have Meniere's disease. The reason I'm saying finally is because the last 4 slides, they've all seemed quite similar. They're all having vertigo and some element of imbalance, but there's just very slight differences between all of these inner ear disorders. So with Meniere's, the main thing I would say, especially in terms of exams, it tends to come in a triad of sensorineural hearing loss, vertigo, and tinnitus. In terms of a history, they may also complain of oral fullness. With regards to management, you would want to refer to ENT just to make sure that there's nothing else like insidious going on. Otherwise, quite similar to the other inner ear disorders, it's more about symptomatic relief with helping with the vertigo. Okay, so earlier we were talking about ototoxic drugs. Here's a very helpful mnemonic. The last one, Redmond syndrome, is basically a hypersensitivity reaction to vancomycin, and it can cause things like ear pain. Something to keep in mind in terms of what could be causing some symptoms outside of all the disorders we were talking about earlier. Right, so I think that was the end of the ear part of this presentation. Bit of a whistle-stop tour. Appreciate it can seem overwhelming. Like Rupali was saying earlier, the best thing to do is keep practicing questions and go through your question banks just to make it all really stick. Moving on now to nose presentations or nasal presentations. We're starting off with allergic rhinitis. It's very common, especially in summer months, is IgE mediated, just as most allergic reactions are. Can be related to the season or the time of year, as well as some jobs. If say someone works as a plasterer, they might be around a lot of dust. Symptoms, as I'm sure you guys are very familiar with, include sneezing, feeling that their nose is blocked, or having a lot of clear discharge, which is usually indicative of some sort of inflammation. In terms of management, you can start off quite conservative, avoiding the allergen, and you can then scale up according to the severity of your symptoms. So a lot of people get on quite well with an antihistamine, which helps block that, that allergic reaction and therefore help manage their symptoms. And yeah, the more severe the symptoms get, I guess the stronger the steroids you would consider. Okay. In terms of nasal fracture, essentially a broken nose. This can, I'm sure you can imagine, happen from trauma, especially if someone falls and has a head injury, you would be worried about a nasal fracture. If on assessment you see a nasal septal hematoma, you would be worried about a risk of necrosis because there's an interruption of blood supply to quite a small area. Usually management in A&E, they can reduce it, or if it is more severe, they may need manipulation under general anesthetic.
Yeah, for nasal fractures, again, in A&E, if you've got anybody with any sort of facial trauma, a lot of people forget to check the nose. And obviously that can lead to like complications where they can have necrosis if you miss the hematoma. So look inside the nose and try to see these symmetrical boggy swellings.
Yeah, definitely. Another thing that people do commonly get is nosebleeds or epistaxis. There's two broad areas of the nose. You have the anterior section and the posterior section. So the anterior section's blood supply is from the Kisselback plexus or Little's area. It's a very vascular arterial area. So a lot of nosebleeds can happen at the front of the nose because it's very vascular. And the posterior section of the nose is supplied by something called the Woodruff plexus, which is quite venous, and it's less common really to get nosebleeds there. Common causes are trauma. So before we were talking about any sort of head injury or hematoma. Other causes can be cocaine. I remember that being a popular question on question banks, just because it really thins down that skin and makes the those vascular areas more friable. Other risk factors or things to think about is if a patient is on blood thinners or has clotting disorders, their nosebleed might be more prolonged and you'd be more worried about it not self-resolving. In terms of management, usually some conservative management is good enough. So asking them to lean forward so that you reduce the risk of them aspirating the blood, opening the mouth. But if you can see the source of bleeding when you're having a look in the nose, you could do silver nitrate cautery or heat cauterization just to kind of plug the bleeding. But if you can't see the area, you could do some anterior nasal packing, which essentially just stops the flow and hopefully help those blood vessels clot. Okay. So I think that, oh yeah, no, fine. We have nasal polyps, which is essentially, polyps are like benign growths, can happen anywhere in the body, but obviously nasal polyps happen in the nose, tends to be associated with asthma, aspirin sensitivity, cystic fibrosis. Just as you have different triads in a lot of areas of medicine, you also have a triad here. So we have Samter's triad, where if someone has asthma, they also might have aspirin sensitivity, and they also might have nasal polyps. It's not necessarily each one is causing each other, but if someone has one, they have a high likelihood of having the other stuff. Symptoms, they may feel, oh, my nose feels blocked all the time, because it is a physical swelling inside the nose. It might cause irritation inside the nose, causing rhinorrhea, sneezing, and it can also affect their sense of taste and smell. All nasal polyps, you would refer to ENT, because you want to do a proper nasal examination, make sure nothing sinister is going on, especially if it is unilateral, because that raises your suspicion of some sort of malignancy. If that's all okay, then the usual management is with steroids, as with most things in ENT, I feel, just to help reduce the inflammation. I think that might be the end of nose stuff. Yeah, and now we're moving down to the throat. So I hope you guys are doing okay. This really is a whistle-stop tour, but feel free to stop me at any point. Okay, so tonsillitis, I'm sure you guys are familiar with what tonsillitis is. Essentially, it's inflammation of the tonsils that sit at the back of our throat. It can be caused by viral infections, can also be caused by bacterial infections. So If a patient does present with, it's quite difficult for me to swallow, this is quite painful, I feel really hot and feverish, and when you do an examination at the back of the throat, you may notice red or enlarged tonsils. That's usually indicative of tonsillitis. In order to know how to manage it, the central criteria is quite helpful. So the central criteria basically helps you decide, is this likely to be caused by bacterial infection, and therefore will this patient benefit from some antibiotics? Because quite commonly tonsillitis is caused by a virus. So you can see on the slide here, the central criteria include tonsil exudates. It's usually little patches of exudate. Do they have tender anterior cervical lymph nodes? No cough, as if they have a cough that suggests more of a viral infection, and do they have a high fever? If they do have these sort of things, then you would want to start off with phenoxymethyl penicillin if they are not allergic to penicillin. If someone's having recurrent tonsillitis, so there is very specific guidance, so you can see that written in bold here, they may benefit from a tonsillectomy. The reason why there's such specific guidance is because, as with all surgery, it does carry a risk. So I think before it was something that was done quite routinely, but now there's an appreciation that there are risks involved, and therefore it shouldn't be done unless it is indicated. A complication of tonsillitis can include quinsy, which is essentially a peritonsillar abscess. So when you're looking at the back of the throat with tonsillitis, you can see usually both tonsils are red, swollen, inflamed, whereas with quinsy, you would see a swelling kind of medial to the tonsils. And if it looks like it's pushing the uvula and spreading over to the other side, there you'd be a lot more worried. Okay. Moving on to epiglottitis. So the epiglottis is a cartilage that sits on top of the larynx, and when it becomes inflamed, it really can be quite uncomfortable, painful for the patient, because it's sitting on top of where you breathe. You'd be worried because there's a risk of airway compromise. Usually present with drooling, fever, being quite unwell, and they might also have like an inspiratory stridor, which is more worrying. I would say, to be honest, if someone's having those sort of symptoms, you would want them to go to A&E and to have stronger antibiotics, have a good look down their throat, just to make sure that the airway is still patent. Okay. Okay. Another infection that can affect the throat is something called glandular fever. So this is caused by Epstein-Barr virus, and it's usually spread through saliva. Someone can transmit this for up to 6 months, so it's something that can spread around quite easily because people just don't realize that they have it. In terms of symptoms, people present with severe sore throat, fever, feeling really tired, as you would usually get with generalized viruses anyway. But on top of this, they might also say, oh, I have swelling or pain around my jawline, and that would be cervical lymphadenopathy. On examination, like when you have a look at the back of their throat, you would typically see a white blanket over the tonsils. So before, with tonsillitis, you'd see white spots, whereas with glandular fever, you're more likely to see a white blanket, as well as some petechiae at the junction between the soft and hard palate. Yeah, that's the general presentation. In terms of management, with viruses, it can be self-limiting. However, if they are systemically unwell, they may benefit from antibiotics. It's important to avoid amoxicillin. I'm not sure why, but specifically with glandular fever, amoxicillin can cause a maculopapular rash. Instead, you'd want to give benzyl penicillin. A complication of glandular fever is that it can cause splenomegaly or hepatomegaly. And that's why you would advise someone with glandular fever to avoid contact sports for at least a month, because of the splenomegaly, it would then increase their risk of a splenic rupture, which would, further complicate things. Okay. So laryngitis, you can see in the name, it's in the inflammation of the larynx, and the larynx is essentially where your voice box is. So if you think about, where something is, it might help when you're seeing a question to think about how it would present. So with our voice box, if it's all inflamed, you would get, a hoarse voice, you'd get pain in that area. You may also get upper respiratory tract infection symptoms, such as a sore throat, cough. It's really important if someone comes with sore throat generally, just to do a general exam of the throat, always have a look, make sure that there's no obvious masses, check their tonsils, that sort of thing. And also having a feel of their neck to see if there's any obvious lymphadenopathy. Yeah. If there is things like lymphadenopathy, usually asymmetrical, not really explained by some sort of preceding infection, or it's not correlating when you're having a look at the back of their throat, you would be worried about some sort of malignancy, so you refer to ENT. Otherwise, it's usually self-limiting, and you can do some conservative measures with soothing drinks. Some people find lozenges quite helpful. I should also note, I don't know if it's still in question stems, but tends to be associated with people who use their voice a lot. So teachers, singers, that sort of thing. Okay, so I've been referencing a lot of malignancies earlier. So this is laryngeal cancer. So the main risk factor would be smoking. Smoking is a risk factor for most things. So if you're not sure, smoking is likely one of them. Very similar to what I was saying earlier in terms of think about where it is. If we think about cancer in the larynx, you would still have that hoarse voice. You may have difficulty swallowing, having a sore throat, a neck lump, and of course, these symptoms which you would think about with any cancer. In terms of investigations, a chest x-ray would be very helpful, just to especially assess if there is any metastases, or just to assess if there's any growth kind of pushing on different parts of the upper airways. With regards to management, you would refer via the 2-week wait pathway, and think about things like radiotherapy. Okay. Sinusitis. So this is quite a common presentation, especially in these sort of months. So we have sinuses around our facial bones, essentially, and they're lined with mucous membranes. But when they get inflamed, you can get pain in the face. Typically, people talk about, it feels like there's a lot of pressure in my face, but it doesn't quite feel like a headache, which is higher up. Usually, they get pressure around the maxillary sinuses, and it's worse when they're bending over, so you can imagine that sort of gravity pushing all the inflammatory fluid forward. They usually also have thick and purulent nasal discharge, and as a result, also feel like they're having a blocked nose. It can be caused by viruses or bacteria, but in terms of management, Antibiotics is not usually indicated here. It's usually things to help you kind of get over the infection with decongestants, doing nasal flushes with nasal saline just to help clear the area, and also some steroids just to reduce the inflammation. If antibiotics is indicated, at that point, you would then think, is this patient needing admission? Because sinusitis shouldn't usually require antibiotics anyway. But as you can see on the slide, first line would be phenoxymethyl penicillin. Okay. But I think this is the final slide. So generally with any cancer in this sort of body system, so ears, nose, and throat, you would be worried by a persistent unexplained hoarseness. So there you think about laryngeal cancer. You'd be worried about a neck lump. Again, you would be worried about the larynx, but there could be other things going on. There are other structures in our neck. We have the esophagus, thyroid, and so on. If they're having an unexplained ulceration in their mouth for longer than 3 weeks, that is not responding to treatment, you'd be worried about a malignancy. And any of these symptoms you would refer via the 2-week wait pathway. Right, I think that was the last slide. I hope you're all doing
Yeah,
okay.
that was amazing. Thank you so much. That was very quick, very to the point. I loved it. So I'm going to give you guys a 5-minute break. Those of you who need to leave for your rotations, you can leave now. And then whoever can stay, you're welcome to stay. And then I'll share the ophthalmology presentation and we'll talk about ophthalmology. And Madhura, you feel free to leave as well. Thank you for your time.
Fine. Well, thank you guys, and good luck with all your exams and all your future endeavors. I hope it all goes well. Okay, bye-bye.
Thank you.
I'll stop sharing.
So I can give you 9 minutes. We're at 51 minutes, and then I will present again. Hello, hi. So I'm going to share my screen and we can start with ophthalmology. If you have any questions, feel free to stop me and we can address them right then and there. I'm going to share my screen now. So, a lot of people don't like ophthalmology. I don't like ophthalmology either, but it's really important. Because these are conditions, visual loss and visual changes have a very high prevalence. So it's important to know these conditions and how they present. Uh, my idea behind it is so you get to look at pretty things. So you should know ophthalmology. So what will you learn? You're going to learn a lot of the high yield topics that come for your exam. Um, the ones in bold are the ones that are included in this presentation. I haven't included visual field issues because there's really good videos on YouTube that explain the entire visual pathway, and that'll make more sense than me just giving a snapshot. So these are like short 10-minute videos, and they're really helpful. So I'm gonna put that in the description of this video, and when you are studying, link to that one for those visual field effect issues. So starting with visual assessment is really important. Um, in A&E, we're short on time, so we get a bit creative with how we do visual assessment, but ideally, you're supposed to have a Snellen's chart to check for visual acuity. Very common question is, what do the numbers mean? So 6 by 6 is basically the numerator, the number on top is what the patient's vision is like. So what the patient can see at 6 meters is what a normal person would be able to see at 12 meters or 60 meters. Um, so it basically gives you an assessment of how poor their vision is compared to a normal person. Um, if they can't read the Snell's chart at all, you go move on to finger counting. If they can't do that, you go on to hand movement. If they can't do that, you do light perception. For color vision, there's the Ishihara chart, which looks pretty trippy in my opinion. But you basically ask them to look at it and see if they can read the numbers or not. Coming to the pathologies, conjunctivitis, very common. It's essentially the inflammation of the conjunctiva. It's two types which are most commonly seen. So it's viral and bacterial. The difference being how they present. Uh, a, a bacterial infection is going to present with a pus-like discharge. Because of the pus, the eyelids will get stuck together. So they'll wake up in the morning and like really struggle to open their eyes because it feels sticky. When it comes to viral conjunctivitis, it's going to be serous discharge. So clear, thin, watery discharge is what they're going to have. And they might give you a history of a recent upper respiratory tract infection, and they might have palpable lymph nodes. The management for allergic conjunctivitis is normally that it's self-limiting. Allergic and viral conjunctivitis, they're normally self-limiting. For bacterial, there is antibiotic therapy, which is chloramphenicol. The other option is topical fusidic acid, especially in pregnant women. Um, if it is in kids, so kids again get conjunctivitis very commonly. Uh, they don't need to be kept away from school. They can go on as normal. I used to get a lot of conjunctivitis as a kid as well, and I never got days off, so that's not fun. Coming on to the next one. This is again a very common presentation, subconjunctival hemorrhage, which is bleeding of the blood vessels that supply the conjunctiva or the episclera. Uh, it has different causes. Most of them are just spontaneous. So the patient will tell you they just woke up and they had this red eye and it's really scary looking, so it freaks people out. But other reasons why people can get it is trauma, sometimes just from sneezing, or if they have bleeding disorders. the clinical features are important. So they're going to wake up, they're going to notice the red eye, but they're not going to have any other symptoms. So they only present because either they've seen themselves in the mirror and noticed this horrifying looking eye, or someone's pointed it out to them that, dude, your eye's red, go to the hospital. But they're not going to have pain, they're not going to have like visual changes. So they're generally asymptomatic. In terms of management, if you see someone with a subconjunctival hemorrhage, you have to check their blood pressure because it might be that they're so hypertensive that they've blown a vessel, which has caused the bleeding. It's normally benign, it resolves on its own. If you're not sure why they've had it or if it seems suspicious, refer to ophthalmology and they can sort of do a bit more digging as to what has caused the subconjunctival hemorrhage. The next one is blepharitis. So this is a chronic inflammation of the margins of your eyelids. It's associated with a couple of conditions, which are seborrheic dermatitis, dry eye disease, which is Sicca, and rosacea. In terms of clinical features, it's going to be on both sides. It's bilateral, and it's again bursts in the morning. They're gonna have some itchiness. They're gonna feel like there's the burning, gritty sensation, and they'll have crusty eyelids. As you can see in the picture, there's swollen eyelids here. It's a bit crusty. They've got a little bit of a red eye, and their skin is a little greasy looking. In terms of management, it's a hot compression. They have to keep their eyelids really clean. So if they've got crusting, they have to clean all of that. And if they've got dry eyes, we can give them artificial tears to help with the lubrication. Quite straightforward. Coming to the next one, this I personally find quite tricky because between chalazion and stye, it can get a bit confusing. Now, chalazion or a meibomian cyst is a chronic granuloma of the eyelid because of an obstruction of the sebaceous gland, more commonly on the upper eyelid than the lower one. Some of the risk factors for it are, again, chronic eyelid infections or inflammation, so chronic blepharitis, seborrheic dermatitis, and rosacea. So what it will look like is essentially like a localized swelling on the eyelid, as you can see in the picture here. Treatment is sort of similar, warm compression, they massage the area. If it doesn't resolve for over a month, or if the person keeps getting chalazions over and over and over again, they need to be referred to ophthalmology because they might need incision and drainage if it's a large chalazion, or they might need steroid injections to like bring down the inflammation and reduce the size. The next one is a stye. Again, I used to get loads of these as a kid. It's a local infection of the eyelid margin. There are two types, external and internal, depending on which gland is affected. So the external hordeolum or stye is an infection of the gland of the Zeiss or the gland of Mole. The internal styes are infection of the meibomian glands, which can essentially become a chalazion. They're quite painful. They're very suddenly presenting. They're small, tiny swellings. You might see a punctum. Management there isn't much that you can do. It's self-limiting. If it is infected, if it's causing conjunctivitis, if it's affecting like vision, you can give antibiotics. If it is a very large swelling, because it's really annoying to have a swelling on your eye, if it doesn't go away and if it's like making life hell for the person, if it's really uncomfortable, you have to refer to ophthalmology. Coming to the next one, this is the most high yield slide in this presentation, and the most high yield topic for ophthalmology, which is glaucoma. I'm talking about acute glaucoma in this case. So glaucoma is essentially when there is an increase in the intraocular pressure above 21 millimeters, which is now causing damage to the optic nerve. It's of two types: open angle, where the angle between the cornea and the iris or the ciliary body is open, so there is flow of fluid in that case, but the trabecular meshwork might be damaged or might not allow for proper flow. Closed angle is the angle, obviously, is closed, so there's no flow happening even in that space. Open angle is seen more commonly above 40. It's chronic, it's bilateral. Clinical features are it's going to be a painful red eye. So it's going to be pain in the eye, it can be a headache. They'll have decreased visual acuity, and the symptoms will be worse with mydriasis. So what that means is in your question stems, it's going to say things like this patient went for a movie to the theater or the cinema, and then they suddenly got a painful red eye and they presented to A&E. Or they were at home and they were again watching television in a dark room or watching a movie in a dark room, and then suddenly they had a horrible, painful red eye. The eye, if you touch it, although they won't let you touch it, when you try to massage it, which is a part of the management, it feels really hard because it's like think of a balloon which is like full of water and it's got so much pressure that it's really hard. The pupil is going to be semi-dilated and non-reacting. And the corneal edema will lead to like hazy or dull cornea. They might present with systemic symptoms. So they can have nausea, vomiting, abdominal pain, along with the eye complaints. So don't get distracted just because they're presenting with things like nausea and vomiting and abdominal pain. In terms of investigation and management, so there's something called tonometry, which helps assess the intraocular pressure of the eye. And you have gonioscopy, which helps you look at the angle. So as you mentioned, there's open and close, so you can look at what the angle is actually like. In terms of management, there is medical and surgical management. So as we understood that the pathology was basically that there's a problem with the flow of the fluid. So we're going to try to decrease the production of aqueous humor, or we're going to try and increase the outflow of the aqueous humor. If we're trying to decrease the secretions, we've got a really lovely mnemonic here, which is called CAB. So you've got carbonic anhydrase inhibitors, which is acetazolamide, dorzolamide, brinzolamide. These are all topical, so these are eye drops we're going to be putting in. For A, we've got alpha agonists, which are brimonidine and apraclonidine. And we've got B for beta blockers, so timolol. So these are all going to help reduce the production of aqueous humor. The other bit of the management is we want to improve the outflow. So we're going to give miotics, which is going to increase outflow from the trabecular system. And we're going to give latanoprost, which is a prostaglandin an analog, similar to prostaglandin essentially. And this is going to increase the uveosacral outflow. So miotics, alpha agonists, and latanoprost. Some patients, so the definitive treatment of a glaucoma is going to be a surgical treatment because you're going to have to make that space for the fluid to get out. So they're going to need a laser iridotomy. So you're going to make a hole essentially with a laser or with surgery and allow the fluid to pass through. Happy with that? If you have any questions, feel free to interrupt. The next one is uveitis or iritis. So this is an inflammation of the uveal tract, which includes the iris, the ciliary body, and choroid. It's associated with HLA-B27. So these are your rheumatoid conditions. In terms of your clinical features, it's going to be an acute presentation. Again, a painful red eye. The pupil will be small and irregular because, again, your ciliary body and your iris is being affected. So if the iris can't move properly, it's going to be tiny. Your pupil is going to be tiny. There's going to be some photophobia, blurry vision. Again, it's a red eye. There's going to be a lot of watering. And the buzzword in your question stems is going to be this. So a hypopion is basically this collection of pus in the anterior chamber because there's so much inflammation and pus being generated that it collects and it makes this very visual line. In terms of management, it's going to be an ophthalmology referral. You're going to give them steroids, immunosuppressants, TNF alpha inhibitors, and obviously laser treatment and vitrectomy is further management. Coming to the next one, orbital cellulitis, a very important topic, especially in any when we look at ophthalmology conditions. So it's an infection of the fat and the muscles posterior to the orbital septum, which is in the orbit, but it doesn't actually affect the globe. The risk factors for orbital cellulitis are children, recent eyelid infection. So they'll present classically with a history of they got an insect bite on their eye. So it started as a periorbital cellulitis, and then it progressed to like their eye just getting really swollen. So what it's going to present like is pain, lots of swelling of the upper and lower eyelid, proptosis, so they're going to have out bulging of their eyeball, loads of edema and systemic symptoms. So they're going to have fever and things like that. When you see an eye like that, your gut instinct is going to be, I'm not going to touch that. But you need to be able to open their eye and see what's inside. So you need to, and the patient's going to be terrified as well, but you need to open the eyelids and try to take a look, which is difficult, obviously, because there's so much swelling. But you need to be able to see what's going on with the eye itself. In terms of investigations, you need to do an ESR, CRP. You might need to get a CT of the orbit. And particularly in these patients, you want to check for eyeball movement. So you're going to check eye movements and if there's pain on eye movements or not. In terms of management, these patients have to normally come in. They're going to need IV antibiotics, steroids, and they're going to need surgical drainage of all of the fluid that's collected around the eye. Coming to next one, the retinal artery occlusion. So it's a blockage of the retinal artery, and you can see it in the image here. So it's basically, if you think about how it works, it's essentially similar to how a stroke or a STEMI would work, where you've got a clot. So it can be thrombotic or embolic. So it's a sudden painless, there's no pain at all, visual loss. Depending on which part of the eye, which part of the retinal artery is affected, you might have central or peripheral visual loss. And you're going to have a cherry red spot on fundoscopy, which is classical keyword, buzzword they'll give you in the questions. In terms of management, there's essentially no definitive treatment. But if you think about how strokes and MIs are time sensitive, a retinal artery occlusion is also time sensitive. So you're going to have to identify and treat quickly. So what the treatment, essentially, what you can try to do is try to reduce the intraocular pressure, which will help dislodge the emboli. And you can give IV, for that, you can give IV acetazolamide and you can put pressure on the eyeball to try to like dislodge the embolus. The parallel to this is a retinal vein occlusion. So you've got a blockage of the retinal vein, which can be, again, central or branch. It's a sudden painless loss of vision, but the findings on fundoscopy are different. So in artery occlusion, you had a cherry red spot. In venous occlusion, you can see these little hemorrhages, which leads to like this stormy sunset appearance. They were very creative with names. In terms of management, you give anti-VEGF medications, steroids, and like implants and laser treatments are other options. Coming to the next one, retinal detachment, again, a very important ophthalmology presentation. So it's a separation of the inner surface from the retinal pigment epithelium. So your retina has different layers in it. And when these layers separate, there's fluid that goes and builds up between these layers. Certain risk factors include family history, myopia, if they've had recent cataract surgery, or if they've had trauma to the eye. Buzzwords for how they present. So flashes, floaters, painless visual loss. If you see anything like that on your question sense, think retinal detachment. And a very classic presentation of patients is they feel like a curtain or a shadow fell across their vision. So they suddenly lost vision in one eye or whatever. In terms of management, there's laser therapy and vitrectomy. Coming to the next one, which is sort of related to the previous one, which is vitreous hemorrhage. So it's bleeding into the vitreous and it presents with, again, floaters, flashes, and painless visual loss. On fundoscopy, you can actually see the bleeding. And how you treat it is essentially you treat the cause that's causing the bleeding. Um, Coming to the next one, again, very important, and people get confused very easily. So it's an inflammation, episcleritis, which is the inflammation of the superficial episcleral layer of the eye. And what it looks like is you see like this bunch of vessels around and like almost like out like a something poking out of the eye. So it looks like that. How they present is they've obviously got a red eye, they've got like discomfort, grittiness. And if you try to move the vessels, which I mean, if you take like a cotton swab and try to move it, they'll blanch. So that's again very important to know because it helps you differentiate it from scleritis. And the treatment essentially is self-limiting. Coming to the next one, we've got macular degeneration. So these are age-related changes to the central retina. So these are, which is the macula. So very commonly seen above the age of 50. Risk factors include age, family history, smoking, hypertension. Clinical features include reduced visual acuity. So these are going to be like chronic visual changes. And again, buzzword for your questions are yellow drusen on fundoscopy. When you actually examine the patients, they can't, if you hand them an Amsler grid, which is basically like a bunch of intersecting lines, it looks wavy to them because of all the drusen and changes in their macula. Treatment is there's no definitive treatment, but you can try to reduce the progression. So it's going to be lifestyle changes, working on all of the risk factors that they have. If they're a smoker, they need to stop smoking. If they're hypertensive, they need to control their blood pressure. Management is anti-VEGF medication again, and photodynamic therapy. Oh, I don't know why that says macular degeneration. This is cataract. So cataracts. Again, very common. It's basically an opacification of the lens. Some of the risk factors of cataract are steroids and smoking. How they present is it's going to be a gradual, painless visual loss. And as you can see in the image, it looks like this milky white opacification of the lens. It's very hard for the patients to see in low light or at nighttime. And they see these halos around light. So if you think about, say, driving, you need to be able to look at the signals. So all of that gets really difficult to do because they're seeing these halos instead. And driving at night would be really difficult again. Um, Now, cataracts present in different age groups. You can have children presenting with cataracts. You can have adults presenting with cataracts or using steroids or smokers, and elderly who would just generally get age-related opacification. So if it is a child who has a cataract, they need to be referred to ophthalmology because ophthalmology needs to do its magic, needs to figure out what the best plan for that child will be. If it's an adult, they need to get optometry done to see what their visual acuity is like. Um, if the visual acuity changes are affecting their activities of daily living, if they're having more falls and things like that, then obviously they're going to need treatment, which is surgery, where it's a really cool surgery, which I'd seen during my rotations. It's a microsurgery. They take the lens out, the opacified lens, and they put in uh, an a replacement, essentially like a artificial lens. So that's the management for cataracts. Now coming to eye movement disorders. So for this, you would have to remember the nerve supply of the extraocular muscles. So the mnemonic for it is LR6SO4O3. So LR6, which is your lateral rectus muscle, which is going to help move the eye from side to side, is supplied by the sixth cranial nerve. So if there's a palsy of the sixth cranial nerve, they can't see outwards. If it is the fourth cranial nerve palsy, which is a superior oblique, which essentially has like a pulley-like system. So it moves the eyeball up and outwards, and down and inward. So downward movement gets affected. Um, and they essentially, because you need to look down when you're walking downstairs, they can't do that anymore. Pupil disorders, Argyll-Robertson pupil are are small irregular pupils, and these are bilateral changes. So the mnemonic to remember this is that the accommodation reflex is preserved in Argyll-Robertson pupils, whereas compared to home lady pupil, these are large irregular pupils and they have a slow light reaction. Coming to the last two very important high yield slides, you've got diabetic retinopathy. So obviously the pathophysiology is that they've got diabetes, which is now affecting the vasculature of their eye and is causing changes. So what you need to know for diabetic retinopathy is the staging. So it starts from pre-proliferative, these are early changes, and then moves on to proliferative. So you have mild non-proliferative, which is essentially just going to show you one or more microaneurysms. Moderate non-proliferative, which has microaneurysm, a little bit of some blot hemorrhages, some hard exudates, and cotton wool spots, which are soft exudates. Severe non-proliferative, which is going to have blood hemorrhages, microaneurysms in 4 of the quadrants. They're going to have venous beading in at least 2 of the quadrants and irma in at least 1 quadrant. In terms of proliferative, now this is again very high yield no. Proliferative essentially means now that there are new blood vessels growing to compensate for whatever was happening before, which is a major red flag, because if your body's going to have to compensate and make new things, that means there's significant damage. So it's retinal neovascularization, which can lead to a vitreous hemorrhage, which is what we discussed before. Proliferative is more common in type 1 diabetics, and again, very poor prognosis. 50% people will be blind in the next 5 years, which is why it's important to know the staging. So it tells you a bit about what their prognosis is going to be like. And I've put in an image so you can see the cotton wool spots and you can see like the hemorrhages and microaneurysms. In terms of management, it's obviously controlling the diabetes, laser treatment, and anti-VEGF medication. Coming to the next one, hypertensive retinopathy. So it's again hypertension leading to vascular damage. It has 4 grades, but less high yield to know compared to diabetic. You really need to know diabetic stages quite well. Clinical features in terms of examination are you'd see this AV nicking, so it's arteriovenous. So where the arteries and the veins cross over each other, there's nicking. You have silver wiring or copper wiring. It's because of the way the vessels look in the endoscopy. And you've got papilledema, so that's just edema of the retina. So you've got all of these exudates, you've got arterial narrowing, there's disc edema, papilledema, and blot hemorrhages and some cotton wool spots as well. Treatment again is getting your blood pressure under control, laser therapy, anti-VEGF medications, and steroid injections. That was it. I believe that was quite quick. I hope I didn't rush through. But if you have any questions, feel free to ask now or get in touch with me later, and I'm happy to answer them. As I mentioned before, I haven't included, sorry, let me go to, sorry, let me go here, your topics, high yield topics. In this, I haven't included visual field changes. So I will link the videos that I watch to understand visual field changes, which I think will be more beneficial than me trying to explain it very quickly. But again, I hope the presentation is helpful. Use it when you are revising. If you'd like, print it out, use these cards to help with your revision. Add on your notes. I've left plenty and plenty of space for you to add on things to the management or the clinical features, or if you're comparing two of the conditions. Say, for instance, I haven't included a slide on scleritis, but if you want to compare episcleritis to scleritis, you can put down those as notes. But yeah, do loads and loads of practice, revise, and you'll do, I'm sure all of you will do really well at your exams. Yeah, that's it. Thank you for joining, and I hope that was helpful.